Welcome, Cardiology Update viewers and listeners. I am Manos Brilakis from the Minneapolis Heart Institute and the Minneapolis Heart Institute Foundation. And it is my pleasure to talk today about our research results from the PROGRESS CTO trial that were published in Eurointervention about the development of a perforation score, specifically the PROGRESS CTO perforation score for chronic total occlusion percutaneous coronary intervention. What we know is that coronary perforation is by many operators the most feared complication of percutaneous coronary intervention, specifically when we're doing chronic total occlusion interventions. And being able to assess the risk of this complication happening can be very useful both for planning during the procedure, but also for being alert and knowing what is the likelihood of having this complication happen. So the goal of this specific analysis was to develop a risk score for predicting clinically coronary perforation in patients who are undergoing CTO PCI. We did use the PROGRESS CTO registry, which is a large multi-center registry from several sites, both in the US as well as around the world. And we did have close to 10,000 cases that were included in this specific analysis. We defined as clinical coronary perforation any perforation that required treatment, and we used the logistic regression modeling to derive the score. What we found is that the incidence of clinical coronary perforation was 3.8%. 367 of the nearly 10,000 cases had a clinical perforation, and those patients were older, they had more comorbidities like PAD, they were more likely to have had previous PCI as well as previous coronary artery bypass graft surgery. Also, the patients who had a perforation had more complex lesions. Specifically, they did have longer lesions, lesions who had more proximal cap ambiguity, which, as you can imagine, predisposed to perforation because one is not necessarily sure where the guide wire is going when trying to cross an ambiguous proximal cap. They also were more likely to have a proximal cap, the proximal vessel tortuosity, as well as calcification. So overall, complexity was higher, the comorbidities were more in patients who had perforation. And as expected, patients who had a perforation had lower success, and they were more likely to have adverse outcomes, not only pericardiocentesis, which is anticipated as a treatment for perforation, but also they had higher mortality. They had a higher risk for repeat percutaneous coronary intervention. The overall MACE was higher in patients with perforation at 21% versus 1.4% for the other patients. There are three main types of perforation. There is the large vessel perforation, there is the distal vessel perforation, and the collateral vessel perforation. And what was found in our study, it's actually one of the first analysis of this kind for perforations in terms of type, is that the majority of perforations, 40%, were large vessel perforations. And then about 26% were distal vessel perforations, 11% were epicardial perforations, and then 7% were septal collateral perforations. So similar to what we see in non-CTO lesions, most of the perforations are large vessel perforations, and about a third were Ellis class 2, and about a third were Ellis class 3 in terms of severity of the perforation. What caused the perforation? It looks like undergrade wiring caused the perforation in 36%. In the retrograde approach was the cause in 32%. And the most common mechanism was guide wire exit, followed by balloon inflation, as well as microcatheter advancement. Now, how about treatment? What we found is that in about a quarter, 28% of the cases, what was needed was only reversal of anticoagulation. But in 72%, other interventions were needed, most commonly prolonged balloon inflations in 31%, use of a covered stent in 29%, and pericardiocentesis was needed in 19% of cases. So again, as expected, this is an important complication, and there can be clinical consequences acutely and long term. So how about the risk model we created, the PROGRESS CTO perforation risk model? What we found is that age is an important factor. Use of antegrade dissection reentry as well as the retrograde approach are additional factors. Actually, the retrograde approach confers 2 points. The presence of moderate or severe calcification gives 1 point to the score. And then the presence of a blunt or stumpless proximal cap gives 1 point. So we have a total score that can go up to 6. And then what happens is, with the higher the score, the higher the risk of the perforation. The area under the curve was 0.74, so that's good performance on the ROC analysis, and there was a good fit that we saw as well. And calibration was actually very good as well between the observed and the expected rates of coronary perforation. The range of the risk of perforation is between 0.7 and 11.2%. So patients who have a PROGRESS CTO perforation score of 0, they have a risk of perforation of only 0.7%. But those who have a score that is 5 actually have an 11.2% risk of having a clinical perforation. And when we look at the percentage of patients who have different scores, so that most of the patients have a PROGRESS CTO perforation score between 1 and 2. About 25% is 1, and about 22-23% is 2. When we look at the validation based on the Ellis class, there was again pretty good AUCs for all different Ellis class 0, 1, 2, 3. So overall, the PROGRESS CTO perforation score is a clinically useful tool for determining the risk of having a perforation when performing CTO PCI. And that can be used, as mentioned before, both before the case to discuss with the patient about the potential risks and benefits of the procedure, but also for the operator to plan and know the likelihood of requiring to use techniques to treat a perforation. We also know that the score confirms that the more complex the lesion and the more complex the patient, then the more likely one is to have a perforation. There are some components of the PROGRESS perforation score that are similar to another perforation score which comes from the Open CTO registry, which is called the Open Clean score. And actually the age and the calcification are common components in both of those scores. But the difference is that, again, some of the components of the model in the Open CTO did not translate in PROGRESS CTO and vice versa. But one could potentially use both of those scores to get a more global and more comprehensive assessment of the risk of perforation. In our study, the ejection fraction was not really independently associated with the perforation risk, neither was the length of the CTO that was associated in the Open CTO score. So to summarize, the PROGRESS CTO perforation score is a score that is easy to calculate based on the clinical characteristics. One of the limitations of the score is that it uses the crossing strategy, that is the undergrade dissection reentry or the retrograde approach, which may not always be known at the time of planning of the procedure, as the plans for crossing may change over time. But nevertheless, it uses few clinically important and easily identifiable characteristics to determine the potential risk of the perforation and help with planning and performance of the procedure. There are ongoing efforts to actually validate this score in other databases as well, and hopefully that will provide more information about the external validity of the score. Thank you so much for joining, and if you would like to learn more, please visit cardiologyupdate.com or follow along on social media. Thank you.